All right, let's dive right into this explainer. Today, we're executing a highly integrated mixed-block clinical simulation. We are stripping away the absolute basics and aggressively targeting top-tier, high-yield pathophysiology to help secure that 270-plus clinical assessment score. We're going to strictly analyze the exacting management pathways for complex endocrine and vascular emergencies. This explainer is specifically designed for the focused clinician. We're really testing your ability to rapidly synthesize data, recognize some incredibly lethal traps, and apply absolute therapeutic mandates. So let's get right to work.
Module 1. Prolactinomas in the dopamine axis. So a prolactinoma is actually the most common functioning pituitary tumor. But the true clinical danger here, it lies in the downstream cascading effect of hyperprolactinemia. Elevated prolactin strictly inhibits the secretion of gonadotropin-releasing hormone, or GnRH, from the hypothalamus, and this consequently lowers your LH and FSH. In females, this manifests as amenorrhea, infertility, and galactothuria. In males, it drives impotence and hypogonadism. Now, men typically present much later than women. Because of this delay, the tumor can literally grow large enough to compress the optic chiasm, causing bitemporal hemianopsia, that distinct tunnel vision defect. Just remember, the absolute very first step in working up these symptoms in a female of reproductive age is to strictly rule out pregnancy.
Now, here's the crucial point, the intervention. Unlike pretty much every other structural mass you're going to encounter, the therapeutic mandate here is completely rigid. First-line intervention is absolutely strictly medical. Because prolactin secretion is natively suppressed by dopamine, we essentially weaponize that axis. Dopamine agonists, specifically cabergoline or bromocriptine, are the strict first-line therapy. They don't just reduce prolactin levels and resolve symptoms like infertility, they actually shrink the physical size of the tumor itself.
Let's contrast this with another pituitary mass, acromegaly. This is driven by somatotroph hypersecretion of growth hormone in adults. That GH hypersecretion subsequently drives excessive insulin-like growth factor 1, or IGF-1, production right from the liver. This causes progressive structural overgrowth, facial coarseness, enlarged hands, and most lethally, cardiomyopathy, which is actually the leading cause of death in these patients. Diagnosis strictly requires an initially elevated IGF-1 level, not a baseline GH level. If that IGF-1 is elevated, you absolutely must confirm the diagnosis with an oral glucose suppression test. In a normal patient, a glucose load suppresses growth hormone. But in acromegaly, there's a distinct pathologic lack of suppression.
And this brilliantly illustrates our first clinical variance box, prolactinoma versus acromegaly. We've got two distinct pituitary masses presenting with completely opposite first-line management rules. Prolactinomas are managed pharmacologically with dopamine agonists as a strict first-line rule to shrink the mass. Acromegaly, conversely, strictly mandates definitive initial surgical therapy, specifically a transsphenoidal resection if the patient is a candidate. If surgery fails or simply isn't possible, sure, we use medical therapy like octreotide, which is a somatostatin analog, but it is never the definitive initial step.
Let's put this to the test directly. A 35-year-old female presents with bitemporal hemianopsia, amenorrhea, and a serum prolactin level greater than 200 nanograms per milliliter. Her pregnancy test is negative. What is the strictly mandated next step in her management?
Let's exhaustively break down these 5 distinct options. The correct mandate is option 1, cabergoline. Despite the presence of bitemporal hemianopsia, a serious neurologic visual deficit, the pharmacologic mandate absolutely holds firm. The dopamine agonist is going to shrink the tumor and relieve that optic compression. Option 2, transsphenoidal surgery, is a lethal clinical trap. While surgery is indicated for almost any other pituitary mass causing neurologic symptoms, prolactinomas are the singular exception. Option 3, octreotide, manages acromegaly, not hyperprolactinemia. Option 4, radiation therapy, is a rare adjunct with a delayed response of months to years. It's never a primary acute intervention here. And option 5, oral contraceptives, might induce bleeding, but it entirely ignores the underlying expanding brain mass.
Module 2. Cushing syndrome and suppression kinetics. The diagnostic algorithm for Cushing syndrome is, well, notoriously challenging, and it requires absolute precision to avoid misdiagnosis. Step 1. You must confirm the cortisol excess. This requires a 24-hour urine-free cortisol test, a late-night salivary cortisol test, or a low-dose 1 mg dexamethasone suppression test. You absolutely have to establish that baseline hypersecretion exists before proceeding. Step 2. Once excess is confirmed, you must isolate the plasma ACTH level to determine dependency. And finally, step 3, utilize the high-dose dexamethasone test as the ultimate separator for ACTH-dependent etiologies.
Let's look a little closer at step 2, isolating that ACTH. If the ACTH level is distinctly low or suppressed, the hypercortisolism is ACTH independent. This immediately isolates the source to either a primary adrenal tumor producing cortisol completely autonomously or exogenous steroid use. However, if the ACTH is normal or elevated, the disease is ACTH dependent. This just means the adrenal glands are simply following orders, and you must now distinguish between a pituitary adenoma, which is classic Cushing disease, or an ectopic ACTH-producing tumor.
And that leads right into our next clinical variance box, pituitary adenoma versus ectopic ACTH. How exactly do we separate a pituitary source from an ectopic source? The singular metabolic variable is the high-dose 8 mg dexamethasone suppression test. A pituitary adenoma, while totally abnormal, still retains a minimal degree of feedback inhibition. Therefore, under a massive dose of dexamethasone, it will successfully suppress cortisol production. Conversely, ectopic ACTH tumors, most classically small cell lung cancer, are entirely autonomous and rogue. They lack any feedback receptors and will completely fail to suppress cortisol production even under that high-dose dexamethasone. Okay, let's apply this diagnostic matrix. A patient presents with proximal muscle weakness, central adiposity, and abdominal striae. Lab workup confirms an elevated baseline cortisol, an elevated ACTH level, and crucially, a complete failure to suppress cortisol following a high-dose dexamethasone administration. What is the absolutely mandated next diagnostic step?
Analyzing these 5 options, the failure to suppress strictly mandates option 1, a CT of the chest. The matrix proves this is an autonomous, ectopic ACTH source, overwhelmingly likely to be small cell lung cancer. Option 2, an MRI of the pituitary, is a highly dangerous trap here. Imaging the brain when the biochemistry is screaming at you to look at the lungs delays life-saving oncologic care. Option 3, petrosal sinus sampling, and Option 5, the CRH stimulation test, are utilized only when biochemistry is equivocal between a pituitary and ectopic source, not when suppression failure explicitly points to ectopic. And Option 4, a CT of the abdomen, evaluates the adrenal glands, which we already ruled out the second that ACTH came back elevated.
Module 3, peripheral vascular occlusions and hemodynamics.
First up, we're examining the embolic strike, acute limb ischemia. The clinical hallmark here is the sudden, truly terrifying onset of the 6 Ps: pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, which simply means a cold limb. This is an abrupt event, overwhelmingly driven by a systemic arterial embolus originating strictly from the heart. Think atrial fibrillation or a left ventricular mural thrombus. Make no mistake, this is an immediate limb-threatening emergency.
Now, we've got to contrast this acute emergency with a chronic occlusion, Leriche syndrome, also known as aortoiliac occlusive disease. This is driven by severe, chronic, insidious atherosclerosis strictly at the bifurcation of the abdominal aorta. It presents with a classic, unmistakable diagnostic triad. You'll see bilateral buttock and thigh claudication, absent or severely diminished femoral pulses, and erectile dysfunction.
Our final clinical variance box dictates an absolute clinical divergence in management. Acute limb ischemia is a sudden emergency, demanding immediate systemic anticoagulation with emergent IV heparin, followed by prompt surgical revascularization or an embolectomy to save the limb. Leriche syndrome, on the other hand, is a chronic, insidious disease. Its management entirely focuses on addressing modifiable risk factors: antiplatelets, statins, strict smoking cessation, and exercise programs to develop collateral circulation. Revascularization is reserved purely for severe symptom progression.
All right, here is your final high-stakes clinical assessment. A 60-year-old male with a known history of atrial fibrillation suddenly develops a cold, pale, and intensely painful right lower leg. Examination reveals completely absent distal pulses. What is the absolutely prioritized next step in his management?
Dissecting these highly competitive choices, the clinical presentation is a textbook embolic strike. You absolutely must prioritize option 1, immediate IV heparin. You have to halt thrombus propagation instantly before irreversible tissue necrosis sets in. Option 2, the ankle brachial index, is for diagnosing chronic peripheral arterial disease. Taking the time to measure it right now is a critical, limb-costing delay in care. Option 3, emergent angiography, is absolutely required for definitive surgical planning, but only after systemic heparin is already on board. Option 4, oral clopidogrel, is strictly for chronic disease management. And finally, option 5, subcutaneous low molecular weight heparin,
is for DVT prophylaxis or stable outpatient management, not the emergent, rapid-onset systemic anticoagulation demanded by an acute arterial occlusion.
To wrap up this explainer, I want to leave you with a really high-level clinical thought to synthesize all these modules. When you're analyzing these massive deviations in physiopathology, I want you to consider this. What underlying systemic variables actually blur the line between an autonomous ectopic hormonal syndrome, like we saw with small cell lung cancer, and a paraneoplastic vascular hypercoagulable state? Mastering that precise intersection is what elevates a competent physician into a true master diagnostician. Keep integrating these concepts, and we will see you next time.